Alrighty, since we're running a little bit short on time, let's get going. So after this wonderful talk from Gwen, we are now going to continue with more wonderful talks. We have two stars in front of us, a great duo, Dr. Lucas and Dr. Murinova. You all know them very well. I will say a few words about Dr. Lucas. As you know, she is the director of a headache clinic at UW. She's also a clinical professor of neurology. She is a true husky. She's done most of her training here in Seattle, including School of Pharmacy and then PhD in biophysics and Department of Physiology, postdoctoral fellowship, and then also her medical school. She then left us for New York and she went to Cornell to do her residency. She was at Memorial Sloan Kettering. That's why she knows a lot of people in neuro-oncology. I was wondering why. Now I know. And then she came back and has been working with us for a number of years. As you know, she's a great neurologist. She's really wearing two hats, a MS hat and a headache hat. More recently, more of a headache hat, I guess. She's been featured by Seattle Metropolitan Magazine, Como4, PBS, Forbes Magazine. She's a star, I told you. She's published a lot of great papers. Most recently, she's been working on headache in patients with TBI, traumatic brain injury. So that's your new focus, I guess, of your research. And as I said, she's also a very popular lecturer. She lectures all over the country on a variety of subjects. And if you don't know, she's also a National Geographic explorer, and she likes to spend time with penguins in Antarctica. So that's Dr. Lucas. And our second speaker is Natalia Murinova. Natalia is from Slovakia, from Bratislava, which, believe it or not, is 150 miles from my hometown. And we were probably growing up, at the same time, just this few miles apart in this part of Europe. Natalia graduated from medical school in Bratislava and then moved to the United States, where she did her internship at Henry Ford Hospital in Detroit, as well as her medicine residency. Then came to us, where she did neurology residency and headache fellowship under the auspices of Dr. Lucas, I guess. Natalia is now a very prominent headache doc. She trained a lot of fellows and residents in headaches. She teaches a lot. I send most of my patients to her now. She is also, in her free time, when she doesn't take care of patients, she is teaching high school students. She is an organizer and judge of the Pacific Northwest Brain Bee. I don't know if you guys are aware of that. And she's also a motivational speaker. So without further delay, I invite the duo to teach us about headaches. And I have more evaluation forms, so
actually this was supposed to be a headache discussion, but Sylvia felt that it would be awkward to hang one mic, back and forth. So what we're going to do is I'm going to present first few cases, then Sylvia is going to present some cases, and then we'll leave it up for open discussion, And so now, so today's plan, so we'll discuss some headache tools, what we call our therapeutic armamentarium. We will present some cases which present difficult therapeutic problems for most physicians, and which might not respond to standard therapy. And why we decided to do this, because most of you, when we do the headache lectures, it's usually the basic stuff, but most of you know the basic stuff, most of the neurologists, whether they become neuromuscular experts or other experts, they will deal with headaches, because that's what people decide, that that's the brain. And if someone has headache, who should they see? Well, neurologists, right? Now, and we will discuss the cases as they apply to various treatments. Now, so the main thing, this is actually from a talk from Stu Tepper, and he said, well, what exactly does refractory mean? Well, if you look at regular dictionary, it's obstinate, intractable, unmanageable, could be defined as resisting ordinary treatment. But who is refractory? Is it the headache, the patient, or is it the doctor? So it's a good question, right? So what goes wrong? Why do these patients not respond to treatment? And if you start analyzing, what goes wrong, sometimes it's the wrong dose. Sometimes it's excessive initial dose, and I've had many patients who take one dose of a medication, they are not instructed on a side effect, will have a side effect and say, no way, I'm not taking this medication ever again. Don't even try to tell me that this is a good medication. It could be an inadequate final dose. We start them on a low dose, continue them on a low dose. It might be unrealistic expectations. It might be that the duration of treatment is too short. I've had many patients who will take, who have come to me after seeing multiple neurologists, and they say, I've already tried 40 different medications, and when they start exploring what exactly have they tried, a lot of times they try one dose, don't like how they feel, say, okay, I hate this, I'm going to go to the next dose. And I think that that's where the teaching and being very patient and actually talking about side effects, but saying, you know what, this is only transient, this is not something that will persist forever, but this is something that might happen to you. That's why I'm talking to you about it, but it will usually resolve with time. And being patient. Of course, people do not like to, when they see us, the kind of joke is that they want to be better yesterday, not tomorrow, right? Or wait 2 months to get response to treatment. Often what we use in headache clinics, and this is where we become in the difficulty with the gold standard and trials, because a lot of the trials are monotherapy. If you talk to any of the headache specialists in the country, there is rarely anyone who does monotherapy. All of us use polytherapies. That's what is common in the headache business. However, these polytherapies are very rarely studied. Of course, there's non-compliances. More than 50% of patients, right, are reported to be non-compliant. I'll rest that a little bit. And again, unrealistic expectations. A lot of times I'll have patients who come, and see me, let's say 6 weeks later. They say, doctor, that medication you gave me, I'm not better at all. And, I'll say, well, how often are you having headaches now? And they said, well, once a week. I said, well, how often were you getting them? They said, well, I don't recall, I don't remember. I said, well, initially you were having headaches every single day. So if you have gone down from 7 days a week to 1 day a week, actually you are more than 75% better. And they said, oh, I guess you're right. I guess I am better. But I really want to be much better. I really want to have zero headaches. I mean, that's my goal. And this medication has not delivered zero headaches. So what I have learned from the get-go is to say, with these medications, if you take it every single day, you can expect that you're going to have decreased headaches, maybe 50%. That's, what we can do. But with other treatments, we can do better than this. But I think it's very important to mention it from the get-go, because then people come back to you and say, it's not working. So I'm saying, no, actually it works, you're doing great, but, we probably need combination treatment, we'll need something else. Again, the main one, and now most of the headache clinics in the country, and it's not only in states, are having more than 80 to 90% of patients that they see with medication overuse, with chronic migraine. This is starting to be, a great epidemic actually in the headache centers. Now, so how do you approach a person who quote unquote has a refractory headache? And I think that the number one point that I would say for our residents, but also for everybody else, is you have to make sure you have the correct diagnosis. I can't stress that enough. So whenever I have a patient that is not improving under my treatment, then I have to go and step back and say, I'm probably missing something. Something is off. Something is not right. And we have actually here Dr. Ashish Trivedi, who presented a wonderful case. He can tell you about it later and some of the Sylvia's cases. But a lot of times when something is just not right, you have to step back and you probably are missing something in the diagnosis. There are more than 200 headache types. Most of the time we deal with primary headaches, but we have to make absolutely sure we rule out secondary headaches, because I can't tell you how often secondary headache can be missed. Now, so the first thing is it secondary or primary? And medication overuse is actually considered a secondary headache. But, things change. If you overuse medication, then hemicrania can be bilateral. If you overuse medication, then the headaches change in their presentation. So let's say a low CSF pressure headache can lose its temporal association with time, and so just being aware that it doesn't mean that you're having the correct diagnosis just because it doesn't meet, the IHS criteria. Now, so my first patient is, what do we doubt, and we all a lot of times look, okay, what is the person overusing? It's more complex than that, but, I've called her ibuprofen overuser. This wonderful patient is actually here, an employee at the University of Washington. She works in radiology, And she said, I've been having headaches occasionally since I was a child. However, since 2008, I've been having migraines pretty much almost every day. And my friend, who is a really good friend and who has been my advisor, said, why don't you just take ibuprofen? And that's what I did. And over time, I have been taking 6 a day. But then I'm worried about my kidneys and liver, and I really don't know, is it good or not? And I'm still having these headaches every day. Now, my headaches are located above my eye and above the temple area. It's very sharp pain. It's very intense. Most of the time it's 6 out of 10, but it can be 10 out of 10. Occasionally, when it's very severe, I'll have nausea, vomiting, light and sound sensitivity. I don't have any visual symptoms, no prodromes, no postdromes. And the main thing I really think what's going on is that it's the work. It's working in the radiology department. It's very stressful. And there are fluorescent lights. There is darkness, and I think that that's the main issue. So medication, she was using ibuprofen and Advil. She didn't know that they were really the same thing, multiple times a day. So what Sylvia taught me is always ask how often do they go through the medication bottle. And she said, well, usually I have to buy a bottle of 60 a week, or more. And apart from this, she said, well, I've had some back problems, but it's really not an issue right now. I've had some headaches since I was 16, but really daily they became a few years ago. And I'm very stressed. Again, have a 7-year-old daughter, and I don't really know what to do. So we were going to go back and forth, but so I would have asked here, like Sylvia or Dr. Lucas, what do you want to do? What are you going to consider doing? But this is always a difficult issue. I think that majority of the people have now been sensitized to the knowledge that indeed medications can make a disease worse. We now know that it's predominantly the population of migraine sufferers who is really predisposed to these daily headaches. We do not yet understand the biology, but we're starting to look, again, in things like Leah, since Dr. Ransom is here, and there is some research that I can point to later. But needless to say, if you see someone who has history of migraines, be more cautious with giving them pain medications because they're much more prone towards developing daily headaches. And it's a bizarre concept that medication can make it worse, but indeed it does cause central sensitization and other changes. And so the question, though, what comes to the most patients, a lot of the patients are pretty savvy and educated. They look up internet and they say, I think I have an issue. Maybe the medications are causing it. I'm having a rebound, but I don't know what to do. I tried to stop the medication and I just got much worse. I have to function. I actually saw a lady yesterday in the office whose husband is a family practice physician. She is taking not only OxyContin, oxycodone, but also 10 ibuprofen a day and 10 Tylenol a day. And these are very educated people. It's not that they're and said, well, we're aware of the situation, but what do we do? And this is where there are multiple options, but it's sometimes you just have to understand that it's not easy for the patient, even if they cognitively understand it, to actually change their behavior. And I think that, so there are multiple tricks, but the main ways you can try to get someone off medications is either slow wean them. That's usually more accepted by the patients if they're scared. And, so if you say, how do I do it? Well, you can recommend decreasing it by 1 tablet, every 2-3 days, or by 1 tablet a week, and then adding some preventive medication. The one preventive medication we have been now commonly using as a bridge is a Botox. So Botox can work even if you don't stop overusing the medications. People can have decreased headaches, and sometimes that's a good way for them to get off. The other medications you can use is any of the preventive medications that we have taken from all the other fields of medicine, from antihypertensives to antidepressants to tricyclic antidepressants. So here, like the example from Dr. Tepper, he has a great article there that I recommend. It's called Breaking the Cycle of Medication Overuse Headaches. And I give it to a lot of the patients to read. And I say, look, Dr. Tepper shows you that these are the different ways. And, when they see the black and white, they say, oh, okay, it's not just me. You've seen this before. You clearly know what are you talking about. Okay, I'm willing to do this. And so we use a lot of topiramate. Topiramate, I would say in States, is probably number one used medication. If you say, why? Because it's the only one, along with zonisamide, that has the side effect of losing weight. And majority of the patients that we treat are women who want to lose weight. They don't want to gain weight. So if you tell them that Pamelor can cause weight gain, I think they're going to laugh, and say, okay, next, So if you tell them the Topamax they can lose weight, they're much more willing to do this. Now, tapering medications weekly. Again, if you have 4 butalbital tablets, you decrease it to 1 and so on. And then at the end of 5 weeks, you could be, done with the overuse medications. Now, what I have to tell you is these patients then, it seems, for life are at a very increased risk of getting into the situation again. And it's very easy for them. I have seen patients that have seen only once. They successfully weaned up all the medications, were headache-free for 3 years, and then something happens where they need medication. Let's say they break their arm or have back pain, and boom, and they're back in the cycle, again. So, and being just really aware that this can happen again. Now, so then there is a cold turkey, option where you abruptly discontinue the overuse drug. So it is safe for majority of medications, apart from that if patients are on really high doses of narcotics or if they're overusing furosemide. Now again, you can give them corticosteroids. We do that frequently. If they don't have any significant problems like uncontrolled diabetes, ulcers, and we can ramp up the prophylaxis, again quickly. And you can use any of the alternatives like beta blockers. You can also use acute medications to help them as a bridge. I'll talk about the protocols that are available and that were studied. And so what did I do, for the patient? Well, so she was advised to discontinue ibuprofen, and she decided, she said, okay, you convinced me, I'm just going to try it. I'm just going to cold turkey it. And she said, what do you think? Am I going to be better, worse? I said, well, in 50% of people, they get worse, and 50% of people, they actually feel okay. And we started her on very slow taper of Topamax. She couldn't tolerate more than small doses, and what I did from the get-go, what I always do is being very expressive about talking about side effects. And I said, well, Topamax is nicknamed Dopamax. It can make you dopey. You can have spelling trouble. You can have tingling, paresthesias. You can have some other issues. The food can taste strange, but that will resolve if you take it over time, and you'll feel better. And she said, and a lot of people will say, how you told me the Topamax, I've been having tingling. It's working, and I'm having spelling problems, and they don't feel bad about it, because they know it's reversible and that's something that decreases and goes away with time. But I think it's very important to talk about that. Now, so what are the other things you can do? And we have done that for her as well. Is in the interim, you have to give people a way out. And injectable DHE, it's called actually DHE 45 because it has been available since 1945. Is a medication that is very popular in all the headache centers. IV DHE is more effective than injectable, but in our clinic, we actually have wonderful nurses who train the patients how to self-inject, or if they feel uncomfortable with injections, they can come daily, let's say for 3 days in a row, and that's how long it takes the majority of the patients. Sometimes you need to admit patients for IV DHE. So Dr. Raskin, actually in 1986, published what is now dubbed Raskin Protocol, and he was using repetitive dosing of DHE in a group of patients with intractable migraines. He had actually 55 patients, and what he tried with initially is a test dose of 0.5 milligrams IV. Whenever you give DHE, you have to give some anti-nausea, so he used metoclopramide. And if there was no nausea present, then he decided, okay, how do I proceed then? So if the no nausea was present after the metoclopramide and IV DHE, and the headache persisted, he gave them second dose of IV DHE and then followed it by 1 milligram IV every 8 hours for 2 days. And after 2 days of IV treatment, he then used, at that time there were available rectal suppositories given every 12 hours until the headache was gone. And for the patients that were not responding, they continued giving sub-Q every 12 hours along with propranolol. And if the DHE was still needed after 1 month, propranolol was discontinued and he used ergonomine. Needless to say that after a mean follow-up of 16 months, he reported that the average treatment duration for the DHE was 3 weeks, ranged from 1 week to 4 months after IV DHE treatment, and he had a very significant decrease in people's chronic migraines. Now, Dr. Silberstein then went on and did a retrospective review of 300 patients who had refractory headaches and used DHE 0.5 milligrams IV along with metoclopramide, and he found that the patients, after they tolerated first dose but had persistent pain, again, he continued the same protocol, so followed every 8 hours. He found that majority of the patients, I have it here, were 37 patients were headache-free by 4 to 6 days of treatment. So it's very impressive because here you have patients who come with sometimes with not months but years of daily headaches with medication overuse, and you can cold turkey and use the DHE protocol to try to get them better. Now, he found that this works not only for the chronic migraine but also for chronic cluster and other headaches. They didn't talk about what is the max dose that they've administered. DHE does cause side effects. The main one is extreme nausea, but it can also cause tightness, burning sensation, leg cramps, vomiting. And most of the patients that do it sub-Q themselves, they will talk about that they have a local area of irritability, sometimes redness. So you have to, again, pre-warn them. And what I have found very useful is using ice locally before you inject. And, sometimes, again, if people are needle phobic, then you have to look. You have to no, don't give this option to the people who don't like needles. Now, so kind of repetitive IVDHE summary. So Dr. Silberstein and Dr. Young summarized data from all the available studies on IVDHE dosing, and per their review, if DHE is given for 3 to 7 days, total doses of 10 to 15 milligrams, it's very beneficial in relieving pain associated with rebound cluster headaches and intractable migraines. They recommended giving doses up to 20 milligrams over a 1 week period. The main thing, if it's IV, then all of the studies have done it under medical supervision. So they were monitoring for adverse side effects, tolerability, and dose adjustment as necessary. So one of the other things that has come up is when FDA was approving Botox, they changed kind of the definition of chronic migraine. So they made it very simple for all of us. So now the FDA definition of chronic migraine is if you have a patient who has 15 days of headaches per month or more, lasting 4 hours a day or longer without treatment. They don't differentiate whether it's primary, secondary, meaning medication overuse. There is no requirement to wean. There is no duration requirements. In the past, it was required that you have to have these chronic migraines for at least 3 months, and there is no phenotype requirement. So I'm moving on to my second case, and then we'll give time to Sylvia. So my second case patient is a 55-year-old lady who had history of migraines since she was probably in her 30s. They were formerly episodic, and then they started getting into chronic migraine in the setting of she was taking 3 butalbital caffeine acetaminophen, also known as Fioronil tablets per day, and she was doing it for the last 5 years. And she was saying, you know what, my primary care physician has chronic migraines. This is the regimen he has been using for himself for years. This is the regimen he's using for all the patients. And why I'm here is because at the church, I met one of the nurses who work at your clinic, and she assured me that, you could help me. But at the same time, saying, well, I'm really, really afraid to give up, these tablets because this is the only thing that works. And so one of the things from Dr. Tepper, what he stresses, and I have to tell you, I have been burned on this once, don't underestimate the consumption of butalbital. Many patients supplemented with internet. So I've actually had one patient who reported that she was using only 3 a day. It turned out she was using 15 a day. And needless to say, I did not know that. She ended up in the hospital because I really, believe that that's, with very severe withdrawal. So, and I was lucky because nothing bad happened. But whenever I hear butalbital or any opioids, I take more steps now to try to clarify, not only with pharmacies, but there are registries and so on where you can find out. Also, what you can do, you can draw a butalbital level, and again, patients underestimate, and they will tell you that they're using, let's say, only 3 a day because they're shamed, embarrassed, they don't really want to admit that they're in a problem. And if it's elevated, then the consideration is inpatient hospitalization because you have fairly high risk of withdrawal seizure. If butalbital level is low, as it was in my patient, then you can proceed with outpatient wean. So the other thing you can use to help with the weaning from butalbital, and this is the detox rule of thumb, is you can use phenobarbital for the wean. And I know phenobarbital is not super popular with the younger crowd, but I have to tell you, when I was at Harborview with Dr. Kopas, we used to give it to all the patients who were alcohol intoxicated for withdrawal, and Dr. Longstreth can comment on the current use of phenobarbital. But phenobarbital at low doses can be very effective medication that can help you very significantly with withdrawal symptoms. How long does it take you to get it back? It's usually a few days. Yeah. So the question was, how long does it take to get levels of medications like butalbital back? So, a lot of time people don't use the butalbital just for the pain. They use it as anxiolytic. Anything that is barbiturate, people like when they have severe anxiety. It makes them feel calmer. So you have to realize that, and you need to do something about the anxiety, because that's a big part that feeds into the fear. So I would always consider using SNRIs, SSRIs, buspirone, and again, be careful with the butalbital withdrawal. Now, so what do you do, in this case? So in this case, again, it depends, how much the people are overusing and how confident do you feel that the patient is going to succeed, how motivated are the patients. And in my case, the patient was extremely motivated. She had big trust in her friend, and she really came with the idea, yes, I'm going to help her. But I have to tell you, it was not an easy appointment, and she kind of left where I could see that she was fearful that she was not going to succeed. Now, there's a lot of comorbid and psychiatric problems. And so what are the other options that you could use for intensive treatment? So you could use, we've talked about Raskin protocol, IV DHE. IV neuroleptics are very popular. IV valproate, IV magnesium, IV lidocaine, IV Toradol. You could use IV ondansetron, Zofran. You can use IV steroids, IV antihistamines. We have done also occipital nerve blocks, and sometimes they work in refractory patients. Now, so why use IV chlorpromazine? Does it make sense or not? Well, you can put the person to sleep. You could use other neuroleptics. That's the goal. So you get them to sleep. They're not going to feel pain, right? So very, very effective. You could even use it. I have seen queries where they use it in Canadian ERs for treatment of intractable migraines. And you can start with 10 milligrams IV. You could use it up to 3 times a day. There are no significant side effects in the studies. The main thing that they stress on all the websites is risk of QTC prolongation and orthostatic hypotension. But in the studies and the patients they have done, they actually didn't have this adverse side effect. Now, what about IV Depakote? So it turns out it works really effectively. So Dr. Matthew has been using this, Nina Matthew has been using this protocol. The only thing is it works only if you use it as if you were treating status epilepticus. So you need to give it rapidly IV. If you give it slowly over half an hour, it's not as effective. And so then it depends, are the nurses that are giving it comfortable, or are you willing to push it, or are you willing to stand there to make sure that the person is not getting into some kind of arrhythmia. I would check serum pregnancy test first if it's a female. It may be repeated, and I have used this protocol where I have started with 500, then repeated it in an hour. it can be an excellent choice in patient who has actually both cardiac issue and bipolar disorder. We have used it in patients who have had cardiac transplants and other issues with severe intractable migraines. IV magnesium, so this is a really great option for the pregnant patient with status migraine or intractable migraine. Now, magnesium is inhibitory. You can use dose 1 to 2 grams IV over 10 to 20 minutes. We had one patient who by accident got 8 milligrams. She made 80 grams, I'm so sorry, but she made it, but she said she didn't like it too much at that level.
Natalia, I just
yes.
have to, I'm suspicious about this one because magnesium does not cross the blood-brain barrier.
Right.
So it doesn't get into the brain.
So this is the excellent comment that Dr. Ransom, actually I made the same comment years back at one of the lectures. There was, and I'll remember in a second who was the speaker, but I said, well, I don't buy this because IV magnesium does not cross blood-brain barrier, and I was assured that the current thinking is that during the status migraine you could have disrupted blood-brain barrier, and so the things that don't typically work at normal states could potentially work. I don't have any proof or disproof,
Yeah,
but
I'm from Missouri. You have to show me that.
So,
Is that also the case for eclampsia?
preeclampsia,
It's also
yes.
the case for eclampsia that it doesn't get across.
It goes in by active transport, and you can get a steady state
But it
in the
works.
brain in 5 hours.
It works, but the studies have been done
So
repeatedly.
currently the discussion is between Dr. Ransom and Dr. Lucas about IV magnesium getting or crossing to the brain, which is an excellent discussion, and I'm sure we'll...
Maybe it doesn't need to be in the brain.
and
That's the
the
point.
other point is, by Dr. Bird, does it really have to be in the brain to work? And it might not need to be in the brain to work. Needless to say, we have a number of patients who find this very effective in their status migraine. And even the non-pregnant, I have several non-pregnant women who have come, like I have one patient who comes maybe once a year, and she said, I have very severe status migraine. I would like IV magnesium. It seems to work like a charm for her. Again, good option if you have patients, who are pregnant, because then you're not going to get in trouble. And Marcel Begal had a study where he found that it works much better with migraine with aura. So, all of those points are really well taken. So, now, why would you admit someone with migraine? And we rarely do. We would sometimes like to, but it's kind of complicated. And patients who are doing poorly, if it's emergency, if someone is suicidal, dehydrated, if they're failed outpatient therapy, if the patient is desperate, if the family is desperate, doctor is desperate, and none of them are getting better. The only thing that I have observed is it's not as simple as, okay, you admit them, you get them out of whatever they were overusing, and they do much, much better in the hospital with IV DHE, but then you get them back home and they're back in their original situation, and sometimes, unfortunately, it doesn't work out. So this is getting to Dr. Lucas' talk. So here you go, Dr. Yes.
You do.
You have more than enough time. Yes. No.
Thank you. Is this it?
Yeah.
Okay. Thank you. I want to talk about some patients that I saw in the last couple of days or weeks, and here's one I saw last week. And I think the cases I'm going to talk to you about are ones that you might see rarely in your careers, but I think the better point is if you don't recognize them or know that they're around, you'll never see them. And like Natalia said, you kind of have to make the right diagnosis. That's the most important thing. This gentleman is really quite interesting. He's a 67-year-old man, and as of last week, and he's a retired heavy equipment salesman, and he had no family history and no history of headaches, but 3 years ago his headaches came on and they never went away. And they're typically quadrant headaches, like you might expect from cluster. They were always his right eye, right temple. Sometimes they'd radiate posteriorly. But he said, they're so bad, it knocks me to my knees. And I'm sitting there saying, yeah, okay, that's fine. Because whenever you look at a someone that says they've got an 18/10 pain, you just sort of have to say, well, take that with a grain of salt. And then he was hit with one of these episodes, and the guy turns white like your clean coat, slides down in the chair. He can't talk, he can't listen, he can't do anything. This one lasted maybe a minute, this attack, and he goes right back, and it takes him a while to get over that pain, but it's very dramatic when you see that happening. He gets from 2 of these attacks an hour. He had 2 when he was in my office, to about 20 an hour, and he'll say he gets 100 a day. It's probably not 100 a day, but he gets many a day. Occasional light sensitivity, but no other issues. And what I asked him about autonomic symptoms, because you always, you're thinking here with these quadrant headaches, is this cluster? What else is it? So you always want to ask about a red eye, a droopy eye, lacrimation, congestion. And he said, no, I don't get any of that. And his wife says, honey, your left eye droops when you get these, and it's the wrong side. So, again, take that with a grain of salt. Plus, once in a while, he rarely gets left side or vertex or occipital headaches. But keep in mind, and Natalia had this on one of the slides, that if you're starting to overuse medication, sometimes these phenotypes that you're talking about will change. And he's taking 3 Vicodin, the 10 milligram hydrocodone one 6 to 8 times a day. He had an on-the-job injury. He's a heavy equipment guy. He's taken a crane out of the back of his truck. It starts falling, and he kind of moves and twists and back and tries to save it from falling off the truck, and he hears a pop in his neck. That, with a past history of neck problems, really means that of all the 13 doctors he went to, he gets a diagnosis of cervicogenic headache. Sometimes medication overuse headache, but that doesn't stop physicians from prescribing more pain medications. He did see neurologists. I have other names. I have the usual suspects. And, unfortunately, cervicogenic headache, which is a secondary headache, was the diagnosis that he mostly got. And they tried, you try pain blocking agents. I think because some of his pain was described as burning, maybe carbamazepine is a good one to try. He'd had neurotomy procedures in some of the upper cervical branches. Muscle relaxants, migraine-specific medications like your triptans, tricyclics, beta blockers, valproic acid. Nothing really worked. Does anybody want to? No, I know you know it.
Which NSAIDs?
He tried, not the one you're thinking of, but but he tried the usual Advil, ibuprofen, naproxen, and even COX-2 inhibitors. So, with the exception of Ashish, anybody want to take a stab at what this is? And you either.
Do you want to say it out loud?
What?
Was saying sunk.
Close. Very close. This is chronic paroxysmal hemicrania. Because, and I'll tell you why, but that is excellent. That's part of your differential. Yeah. First described in 1974, these are multiple short-lived unilateral attacks occurring on a daily basis for years without remission, and that's almost the definition of SUNCT. There's been some episodes of remission. It's got a really wide range of onset, so at 67 you're thinking, oh, it's kind of old, but still I've seen some new cluster patients in their 60s as well. Sometimes people in the family will have migraine, about 20%. Not those particular people, but some of their relatives. There has been one report in the literature of bilateral symptoms, 3 reports of side shift with different episodes, but the majority of patients are having more than 15 attacks a day, and they'll last from about 2 to 25 minutes. His attack, he had nocturnal attacks, like cluster, but the interesting thing that is different with SUNCT than this, and again, not with all paroxysmal hemicranias, but people can have a trigger, just like trigeminal neuralgia. Sometimes you could trigger with, just cold air brushing by the cheek or chewing or something like that. these folks, I mean, with him, if he lifted up his arms to do something, he could trigger an attack. If he turned his head, he could trigger an attack. So, and then I had actually another patient that we squeezed in on Monday, who's like a sportscaster for one of our radio and television channels, who every time he turns to look at the monitor for a game, he can trigger an attack, and it's just kind of the same exact thing. So two of these folks in a week and nothing for years, feast or famine. But during the attack, you usually have an ipsilateral autonomic symptom. Rarely there's descriptions without. This is an example of an indomethacin responsive headache, and that's how you're going to make your diagnosis on whether this is SUNCT or whether this is a paroxysmal hemicrania. Indomethacin is both a diagnostic and a therapeutic answer for this poor gentleman. And in fact, somebody had given him 25 milligrams of indomethacin, but he's a big guy. He looks like a cluster guy. You know, he's a truck driver. He's got, I couldn't resist. What color are your eyes? Are they hazel? They were. You know, this leonine faces and, like, you know, that kind of mane type thing. Why these, genetically it's really fascinating, but he had not been on enough indomethacin. These people need to be on a minimum of 150 milligrams a day, and then you jack it up to 225 unless you've given them an ulcer, and of course stomach protection. So if it is the paroxysmal hemicrania, that headache should go away in 1 to 2 days, and it did. And so he was so happy, he stopped all that Vicodin and had a withdrawal. You know, had terrible withdrawal, so now we're looking for a place to put him in for detox, unfortunately. This is another one that I'm going to be a little shorter with this because you will see this. This is a 32-year-old woman with a 4-year history of daily right-sided headache. For people who have, again, unilateral fixed headaches that never go away but wax and wane in intensity, I want you to think of hemicrania continua. I'm glad it's all Greek to me, but it's easy. Hemicrania, half head, continua, continual. When severe, she would have photophobia and phonophobia, so some of these migraine symptoms overlapping. And there's got to be an autonomic symptom as well with this, and she had nasal congestion. Normal exam and imaging, but no effect of any of the migraine drugs. So you give them Imitrex or any of these other drugs, they just won't work. And she was using a lot of aspirin, Excedrin, or ibuprofen. And the interesting thing about this, not all indomethacin responsive headaches, but a lot of them you can give other NSAIDs and they may have a partial effect, but indomethacin is very, very different. It's really under-recognized, and I think a lot of us will let it skip and we'll think chronic daily headache and we'll look at medication overuse, but again, please think about it. The superimposed exacerbations can last minutes to days, so that's why I think a lot of people will say this is a chronic migraine, and sometimes it gets worse, sometimes it gets better. And of course you can have a course that's complicated by medication overuse, and this last lady could have been going there, but your diagnostic and therapeutic drug is going to be indomethacin. You still need high doses. This is
why does it work?
Indomethacin?
Yeah.
Beats me. I think indomethacin is not completely understood. I don't think it's a simple NSAID, and I think we're just starting to look at indomethacin in animal models of pain. And you can reproduce using models of neurogenic inflammation and be recording the trigeminal nucleus caudalis and give an animal indomethacin, and you can dramatically see like spikes per second from input from the trigeminal go down. So there's got to be a central effect, and I think there's also been postulated that it can change production of spinal fluid. I don't know if any of those.
Does the blood-brain barrier better than other NSAIDs?
I think this, yeah, it does. This does cross the blood-brain barrier.
Because many NSAIDs do not cross the blood-brain barrier.
Well,
ibuprofen does better compared to other NSAIDs.
Right, and I think that's why we'll use ketorolac and ibuprofen and naproxen and some of the others. Like flurbiprofen is a great underused one. You know, you can pretty much tell. I mean, if they work at decent doses, which ones are going to cross even without knowing the chemistry. Because it's 5 after, when are we supposed to get done?
We're supposed,
You can just finish. Just give
we're supposed to get done around now. We're a little bit bad about the timing of these things.
Okay.
We do have a meeting to follow for some of the people in the room, but by all means, finish this case. Let's do this case quickly.
This one's for Ollie. 27-year-old man, sudden onset headache. He's from Wenatchee and really nice guy. His wife did a lot of the talking because he would have some of these episodes in front of you, and it was really amazing. In fact, when I wrote this up, I called it the case of the devil eye, because when he would have his attacks, you know, again, these just sudden onset orbital, retroorbital attacks, periauricular pain, they would be so sharp, so stabbing, so severe, he couldn't do anything. But the really interesting thing about SUNCT is that the autonomic symptoms just arise with the pain, and they kind of go away when the pain's over. That eye would go from white to beet red and then go away as his pain went down in intensity. He would also become teary, and he had ear pain. I have not, I think most people don't have SUNCT patients, but this is kind of the first time that I've seen someone that has vertigo. I'm not surprised at it. He tried indomethacin, triptans, calcium channel blockers, probably more than this. And the only drug that gave him a modicum of relief was topiramate. It decreased the eye redness and the tearing, and possibly reduced the stabbing somewhat, but it was causing cognitive side effects, and because he orders car parts for a living, he was making a lot of mistakes. This, unfortunately, is a condition with no treatment. It's the rarest of the unusual cases, described in 1978, and up to 10 years ago there were about 26 cases in the literature. They're brief episodes of pain like the others, occurring 3 to 100 times a day, always ipsilateral and always with autonomic symptoms. They may have periods of refractoriness. So this is my last slide. I think when you're looking at these indomethacin responsive headaches, so we have to leave SUNCT out of there, but when you're looking at the indomethacin responsive headaches, a lot of times you're looking at the attacks a day, but 1 to 40, 6 to 77, 2 to 30, I mean, you're having a lot of overlap there. It doesn't help you. What helps you the most is to look at side locking. So you'll see that in cluster, you'll see that in the chronic or episodic paroxysmal hemicranias, you'll see it in hemicrania continua, and you'll see it in SUNCT. And there usually are going to be quadrant headaches. The difference between these short-lasting one and clusters, I mean, the first thing is that your cluster is going to be a 15-minute to a 3-hour headache. So cluster is longer, but you're not going to get that confused with migraine, because migraine is going to be 4 hours to 3 days usually. They're all going to have autonomic features present, and they're all going to have multiple attacks a day, and the attacks are going to be short. And many of them are going to be differentiated by their response to indomethacin. Hemicrania continua will, and the chronic or episodic paroxysmal hemicranias. Cluster is going to be responsive to your IV sumatriptan, or sometimes intranasal if you can get it in there fast enough, and oxygen, which the others are not responsive to. These are very interesting. The trigeminal autonomic cephalalgias are really quite interesting because, you know, again, you get this co-occurrence, and they're very co-occurrent in time of the pain and the autonomic symptoms. We don't know much about them at all, probably because we don't have that many patients. But of the patients that you can get in a scanner, a functional MRI image, or a PET scanner, actually, in the PET scan, we can see patients that have migraine have increased cerebral blood flow in the posterior fossa, in the area of the pons. the one or two people we've managed to get with these short-lasting trigeminal autonomic cephalalgias look like they're kind of a cross between cluster and migraine. The cluster is going to light up in the thalamus, hypothalamus area, and the ipsilateral carotid. And we've gotten, I think it's only one hemicrania continua person in a PET scanner, and you get a little bit of high flow in the thalamic area, hypothalamic area, and the posterior fossa. And that's all we know. I've asked for volunteers to do research, but we obviously have no animal model for this, so it's going to be hard going. But keep that in mind, and that's my final message. Thanks.